Afternoon, everyone, or namaste in Hindi. It's my pleasure and honor to introduce today. So today marked like number 20th day of our liver imaging series. There was one day that was not given in the middles, but I still would consider this 20th day of our liver imaging series. It's my pleasure and honor to introduce Dr. Michelle Mandurata Lala. Michelle is an associate professor at the University of Michigan, abdominal and cross-sectional interventional radiology. She is lead radiologist at the Liver Tumor Board. She is the chair of LI-RADS Treatment Response Working Group and the co-chair of the Society of Abdominal Radiology HCC Treatment Response Disease Focus Panel. She is the co-chair of Global Interventional Clinical Outcome Registry, which is a committee in charge of maintaining national and international research database for HCC treatment. She is the co-PI on NIH grant for histotripsy, which is new ablation technology research. She is working in a small animal lab on this new ablation technology and will be running the first US trial on HCC liver cancer treatment, which will be in conjunction with a radiologist from the University of Wisconsin. She will be also the co-guest editor of Abdominal Radiology Special Edition this winter, focusing on HCC treatment response. We all, I think, know Michelle. She is the most popular and superhero of this series, and without further ado, we all look forward for listening to her lecture about HCC LI-RADS treatment response after locoregional therapy. Michelle?
All right, thank you, Khaled. That was too nice. I want to start by thanking Khaled, first of all, for giving me the opportunity to speak. This has been a wonderful course, lots of really wonderful lectures. I've learned a lot, so thank you, Khaled. Really quickly before I start, I also want to thank Victoria and Claude for giving me the opportunity to be part of LI-RADS steering committee and working groups. I would not be where I am without them, and so thank you to them. They're great radiologists, researchers, educators, and leaders, as well as great friends. And then finally, last thing, I just want to say thank you to Richard. Richard is really the one who created the LI-RADS treatment response algorithm for those of you who use it, and he has been an amazing mentor over the last couple of years, mentored me into his position, and so I want to thank him. And more than just being a great mentor, he's become a great friend. So I want to say thank you to him as well. So let's go ahead and start now. The title of my topic, Hepatocellular Carcinoma, LI-RADS Treatment Response After Local Regional Therapy. I have no disclosures. So let's start with, why do we need tumor response criteria? Well, first of all, tumor response assessment guides our clinical management for these patients. First of all, do these patients remain on their current medication regimen, on their current treatment regimens? Do they continue routine imaging follow-up after treatment? Or do they need to undergo additional interventional bridging therapy? It also helps for us to determine their transplant eligibility. Many of these patients are getting local regional therapy to downstage them so that they can become eligible for transplant. So that's why. What about how? How do we assess HCC treatment response? First thing is, you need contrast-enhanced cross-sectional imaging. This should be multiphasic imaging. So you can do CT with intravenous contrast, or MRI with extracellular agents or hepatobiliary agents. Now, currently, the contrast-enhanced ultrasound is not part of our current algorithm. It will likely be in the next version, so you can look for that in the upcoming years. The second thing for how we assess HCC treatment response is that we need to understand the pre-treatment enhancement characteristics of the tumor being treated in order to accurately interpret your response post-local regional therapy. So what do I mean by that? Well, if we don't know how the tumor enhanced pre-treatment, we don't know what the response is post-treatment. So remember, we have our typical or our diagnostic HCC enhancement patterns pre-treatment. That's where you have your arterial phase hyperenhancement, you have portal venous washout, plus or minus a capsule, and or threshold growth, and that gives you an LR5 lesion. We also have atypical HCC enhancement patterns pre-treatment. We have our LRM, which is arterial phase rim enhancement. We have those HCCs that just demonstrate washout and may have other ancillary criteria, LR4, or those that demonstrate arterial phase hyperenhancement with ancillary features such as T2 and diffusion restriction, to name a few, which are also LR4. The majority of these are usually biopsy-proven HCC before they're treated. However, again, and I'll get into it later, you need to know how the tumor enhanced pre-treatment. And then the third thing is we need to understand the expected post-treatment imaging appearance after each form of locoregional therapy. So remember, there are many forms of locoregional therapy. We have percutaneous ablation, we have arterial-based therapies, both non-radiation and radiation-based, and we have external beam radiotherapy, as well as systemic and biological therapies. Now, each form of therapy results in a different expected enhancement pattern of the tumor, and so we need to be aware of that in order to decide what is the response of this tumor to our locoregional therapy. I'm not going to get too much into what exactly these therapies are. I mean, of course, we're going to review them, but there's a paper in Radiology Cancer Imaging from 2020. I have the reference down there that goes into that in great detail. So let's move on to our LI-RADS treatment response classification system. So now we talked about why we need it, how we need it, or how we assess. Third thing is, what are we using to assess? So the LI-RADS treatment response algorithm has three distinct classifications or categories. Non-viable, where it's definitively non-viable, definitively viable, we know there's viable tumor, and then it's got this other category, this equivocal category. And basically, that's where you see some enhancement around your treated tumor, and you're not sure if that's true tumoral enhancement or enhancement related to post-therapy changes. The LI-RADS treatment response algorithm does not apply to all forms of locoregional therapy. There are many forms of locoregional therapy, as you see here. It does not apply to surgery or systemic therapy in its current iteration. The LI-RADS treatment response classification is unique to other response classification systems because it assesses lesion level response, unlike these other classification systems, MRESIST, EASL, RESIST, which are assessing response at a patient level. And so why is that important with hepatocellular carcinoma? Remember that locoregional therapy treats each lesion independently. A patient may have 3 different tumors in 3 different parts of the liver, which are treated with 3 different forms of therapy. So we want to make sure we can characterize each lesion independently and know if there's viable tumor or not, because maybe 2 tumors are non-viable, but 1 is, and we want to make sure that we treat that in order to keep them in, Milan criteria, keep them eligible for transplant, and keep them from progressing. So our LI-RADS treatment response algorithm, here's our criteria and our table. I'm not going to get too much into detail for this. You can look it up online, but there's a few key things I want to point out. In the LRTR non-viable category, no lesional enhancement is there, but another important thing that we have there is treatment-specific enhancement pattern. So what do I mean by that? Again, like I mentioned earlier, you have to be familiar with the common post-treatment appearances for each form of locoregional therapy in order to accurately assess treatment response. The other thing I want to point out with this table is LRTR equivocal, and kind of how I already mentioned, this is enhancement that you're seeing now that is atypical for treatment-specific expected enhancement, which would make it non-viable, and it doesn't meet the criteria for probably or definitively viable either. So why do we have this equivocal category, and is it important, or why is it important? So remember, LRT, our locoregional therapies, are targeting not only the tumor, but the adjacent hepatic parenchyma as well. So as a result, you get geographic and or amorphous arterial phase hyperenhancement, not only in the tumor, but around the treated tumor from the altered parenchymal perfusion. And this can sometimes mimic viable disease, which allows us then to use this LRTR equivocal when we're unsure of what it is. What is the result if we call something equivocal? Well, there's definitely the possibility of untreated viable tumor in the patient. Remember though, these are small areas, possible small amounts of viable tissue. If it was something large enough, we'd probably be comfortable calling it viable. And the HCC doubling time is very slow. It's about 90 days on average, plus or minus, as you can see here. Most of these patients are followed up Q3 months anyways. So in 90 days, if that's your average doubling time, most of what we're considering, we're not sure if it's viable or not, is small. And so even if it doubles, you still have a very small amount of viable tumor. And the wait and watch approach prevents these patients with tenuous liver function from being retreated too early. These patients have a lot of morbidity and mortality more from their underlying chronic hepatocellular disease than the tumor itself. So, you know, sometimes it's worth just waiting, because if you treat them too early, you could really tip them into hepatic failure and cause more problems for the patient related to, you know, decompensation as opposed to the tumor itself. All right, so what is the timing for post-locoregional therapy? This varies per institution. So I think that's something that is a discussion that all of you have with your multidisciplinary clinical services. However, in general, percutaneous ablation, you usually get an immediate post-treatment study, such as a CAT scan, when they're on your table, when you're doing ablation. And then you do one at 1 month and Q3 months thereafter. With non-radiation intra-arterial therapies, again, you usually do imaging at 1 month and Q3 months after that. With radiation-based therapy, so with TARE, you usually do it Q3 months. However, newer protocols are imaging these patients at 1 month and then Q3 months. And we'll talk about that later, why that 1 month imaging can sometimes be a little bit confusing. And with SBRT, again, usually Q3 months. All right, so now moving on, let's get into our different forms of locoregional therapy and what our imaging findings are. So percutaneous ablation, we'll start here. Now, all of my percutaneous ablation cases are microwave or RF. I don't really go into cryoablation or PEI. So what are our expected post-treatment imaging findings after thermal ablation? So the first thing is on your T1 pre-contrast, so MRI, or if you have a CT, non-contrast CT, you get this central area, which is either hyperdense if you're using CT, or hyperintense for MRI, centrally within the treatment cavity. And that is coagulation necrosis. That does not enhance. On your post-contrast images, you'll get this thin, continuous, smooth rim enhancement along the tumor. Centrally, you should not see any enhancement. And you want to make sure this smooth rim enhancement is continuous. If you see a little break in it, that could be a sign that there might be some microscopic viable tumor. And then finally, you get some mild peritumoral, ill-defined geographic areas of arterial phase hyperenhancement within the parenchyma adjacent to the treatment cavity. The key here is that there should be no residual arterial phase enhancement within the treated tumor after thermal ablation. So here we have a patient with an LR5 hepatocellular carcinoma treated with microwave ablation, and at 1 month you can see there's no enhancement within the tumor. You have the smooth, thin peripheral rim of enhancement. This is compatible with LRTR non-viable disease. Here's another patient. Here we've got a T1 pre-contrast image where you see this central T1 hyperintensity, which is your coagulation necrosis. Along the margin, we see this hypointense area, not really sure what it is. We give the patient contrast, and you can see that there's nodular arterial phase hyperenhancement. So this is then compatible with LRTR viable disease. How about this patient? I don't show you the pre-treatment image here, but you can see here is the ablation cavity in this patient. It's not enhancing. However, medial to the ablation cavity, you're seeing this area of somewhat nodular tubular arterial enhancement. And on the portal venous phase of imaging, you're seeing that it's washing out. So this is viable disease. How about all this other area of enhancement, though? And this is frequently what sometimes you'll see after ablations. You'll see multiple areas of enhancement. So how do we distinguish if there's viable tumor or if it's just parenchymal enhancement? And I really like this case because you can see this area that's demonstrating washout. Well, we know that's definitely viable tumor. This other area that we're seeing here, where you're getting this more geographic, wedge-shaped area of arterial phase hyperenhancement, when you look at it on the portal venous phase of imaging, you're seeing that it's now iso-enhancing to the parenchyma. So it's normalizing to the parenchyma. And so I think this is a really nice example showing what your perfusional changes look like versus what viable tumor looks like. All right, so moving on now, we're going to go to our non-radiation arterial-based therapies. So what are our types of intra-arterial locoregional therapies? You've got conventional TACE, where you use iodized oil mixed with chemotherapeutic agents, followed by embolic microparticles, and you can see here you've got the Lipidol. This is a non-contrast CT and it's hyperdense. You can also see some staining of the adjacent parenchyma in this patient, which is a common feature you'll see after Lipidol or the iodized oil. You can also have DEB TACE, which is a chemotherapeutic-coated embolic agents. There can be bland embolization, which is called just TAE, transarterial embolization. And the mechanism of action for these intra-arterial locoregional therapies is to occlude the arterial blood supply to the tumor using embolization, thus causing ischemic cell death with or without chemotherapy. So what are some of our expected post-treatment imaging findings after non-radiation arterial-based therapy? Again, just like we saw with thermal ablation, you can get a thin, continuous, smooth rim of enhancement. The one difference here is that you can often get exuberant peritumoral, ill-defined geographic areas of arterial phase hyperenhancement, which can normalize or remain hyperenhancing on the portal venous phase of imaging. The key, again, like I showed with thermal ablation, is that there should be no residual arterial phase hyperenhancement of your treated tumor. So let's go to our first case. Here we've got an LR5 lesion within the left lobe of the liver. The patient is treated and with TACE, and as you can see on this non-contrast CT, you can see the thiodol and you can see the staining of the liver. Now, if this patient, let's just look at the CT image, were to get contrast, you could see that it would be hard to evaluate if there's any residual viable enhancement there because this is hyperdense. When you look at the 1-month MRI, you can see that you don't see that Lipidol, and so you can actually see there's no enhancement of the tumor. That tumor is decreased in size, and you can see the smooth, thin peripheral rim of enhancement around this tumor. This is one of the kind of confounding issues with using Lipidol and CT. Many places, however, don't use MRI for treatment response evaluation and do use CT, and so this is a common question. What are we supposed to do with these patients? There's a study, as you can see down here, I put the reference, just came out in 2020. Julia Shapiro, Jeff Geschwind et al. From Yale recently published it. And it's a great study talking about using Lipidol as an imaging biomarker for tumor response after conventional TACE and kind of evaluation with CT. So if you are at a place that uses CT, that's a great reference for you to look at to evaluate. But again, MRI is better for these patients because you don't see the Lipidol, so you can assess for the tumor response assessment a little bit better. All right, next case. Here we've got a patient. I'm just showing you post-DEB TACE images, multiphasic, so from pre-contrast through your dynamic post-contrast. And what we see here is the smooth, continuous peripheral rim of enhancement. We do not see any central enhancement. This is an expected finding, and so this is LRTR non-viable. Now, if any of this smooth rim was nodular or discontinuous, then you would suggest that there may be viable tumor. How about this patient? Now we've got a large LR5 lesion in the right lobe of the liver. The patient was treated with TACE. 1 month later, you can see thick residual tumoral enhancement in this patient, and so this is compatible with what viable disease would be, so LRTR viable. How about this patient? Here we've got a patient pre-treatment who has this mass in the liver. However, we don't have our typical HCC enhancement pattern of arterial phase hyperenhancement. This then was biopsied, and this was a biopsy-proven HCC. So this patient went on to receive DEB TACE. 1 month post-DEB TACE, what do we see? We see a large area of necrosis within the tumor. No enhancement, you can see on the subtractions, but we see this a nodular area by the tumor. Now this is not enhancing. We would expect to see enhancement if there was viable tumor, but remember, this is where it becomes important to know what your pre-treatment HCC or your pre-treatment tumor looked like. In this case, it was a hypoenhancing tumor, and our enhancement or our appearance on our post-treatment study is identical to that pre-treatment, so we know this is viable tumor. So this then would be LRTR viable disease. Here's a patient with an LR5 lesion treated with DEB TACE. 1 month post-treatment, you can see a large area of necrosis. However, along the periphery, you can see this somewhat ill-defined area of arterial phase enhancement. Maybe it's nodular, maybe it's geographic. We can't really tell. There is a little bit of restricted diffusion. Remember, this is an arterial-based therapy, so this is upstream to where the tumor is. So could this be perfusional related to embolization of that artery, or is it tumor? We're not really sure. So at this point, this was called LRTR equivocal. The patient comes back at 3 months, and now we see there's definitive tumor there. You're seeing that this area has gotten larger, there's definite washout, there's almost a capsule-like appearance along the margin, and there's increasing restricted diffusion. So at this point, it's safe to call it LRTR viable, and then this patient was retreated at this point. But again, this is still a very small volume of tumor, remember, so waiting 3 months doesn't really do too much in terms of harm with too much of disease progression. Here's another case. Here is the patient who had an LR5 tumor treated with TACE. I know this does, I'm not sure if this reflects well, but here's your treated tumor, and it's no longer enhancing, but we do have this definite area of nodular enhancement near the tumor. Again, not sure if that is actual tumor or is that geographic. On the image I have portrayed here, it looks quite large, but this image is blown up. This was only actually a few millimeters in reality, so this was called LRTR equivocal. The patient came back at 6 months. Now you can really see that treatment cavity nicer. You are still seeing a little bit of enhancement here. It's starting to look a little more geographic, a little less tumoral. And at this point, it was called LRTR equivocal as well. 12 months now, you can really see that the tumor is definitely responding. All of this area of enhancement we're seeing, this is a delayed phase. So it's no longer arterial. So you're seeing delayed enhancement of all that. So that ended up being just fibrosis post-treatment. And so this was LRTR non-viable disease. So I just showed you an example of where you've got some nodular enhancement and one ends up being viable and one ends up being non-viable. So that's where the equivocal category really comes into play and can be helpful in these patients. So the bottom line, persistent tumoral enhancement equals viable tumor with the thermal ablation and with the non-radiation intra-arterial therapies. We, however, need to understand how the HCC enhanced pre-treatment. And remember, different forms of therapy result in different post-treatment appearances. And so this now brings us into our radiation-based therapies. That last line is key, that different forms of therapy give you different appearances. So let's start with TARE. What are our expected post-treatment imaging findings after TARE? Well, it's very variable, but you can see persistent enhancement of your treated tumor up to, but not limited to, 1 year after radioembolization. What type of enhancement? You can have persistent central tumoral enhancement. You can have just geographic peritumoral enhancement. You can get peritumoral ring enhancement, like we saw with the thermal ablation and the intra-arterial therapies that are non-radiation. And then you can have no enhancement of the tumor. In addition, after radioembolization, there's a phenomenon called pseudoprogression, where you get an increase in size early post-treatment, secondary to multiple factors, including edema, necrosis, or hemorrhage. And over time, this peritumoral parenchymal enhancement can increase and be seen on the delayed phase of imaging with some overlying parenchymal atrophy, which is suggestive of fibrosis. So here we have an LR5 lesion in the right lobe of the liver, which was treated with radioembolization. 1 month post-therapy, you can see that there's no enhancement of the tumor, so this is pretty easy to say LRTR non-viable. And what I want you to see here is this really exuberant arterial phase enhancement in the surrounding parenchyma. So there's a lot of parenchymal changes that you see with radioembolization. And at 3 months, that area gets smaller and that parenchymal enhancement, the geographic parenchymal enhancement, it decreases. This is LRTR non-viable. Here's another example, an LR5 lesion in the left lobe of the liver. 1 month post-TARE, you can see that there's a small area of central necrosis within this tumor right here. But along the periphery, even though we're getting this ring enhancement, you can see that it's somewhat irregular. It's thicker in some areas, thinner in other areas. This is LRTR equivocal. Now, if the other examples I showed you, thermal ablation and intra-arterial non-radiation therapy, if this was one of those forms of therapies, you would say this was viable. This is where radiation-based therapy is a little bit different. Here we would call it equivocal. And at 3 months now, you see all of that has regressed. The tumor has decreased in size. You can see some of the surrounding geographic parenchymal changes. And at this point, depending on your comfort level, you could call it equivocal or non-viable. finally, at 12 months, you don't see anything. So you're comfortable calling this LRTR non-viable. The difference with radiation-based therapy, and the key here, is it's an evolution of changes. So time is really what tells us whether something is viable or non-viable. It's really hard early on because of the imaging appearance of this persistent arterial enhancement to definitively say whether there is non-viability or viability. So equivocal becomes very important in these radiation, in these lesions treated with radiation therapy. How about this patient? Again, an LR5 lesion. 3 months post-TARE, we have a CT, and what do we see? We see there's a good degree of necrosis. However, centrally, there's this area of nodular enhancement. And on portal venous, that has now disappeared. So it looks like there's arterial enhancement and washout. If this had been in TACE or some other form of, thermal ablation, we would have definitively called this LRTR viable. But because this is radioembolization, we would call it equivocal. Because again, like I said, this is an evolution of finding over time after radiation therapy. At 6 months now, what do we see? That lesion is smaller, that area of nodular enhancement is no longer present, and we're seeing increasing fibrosis in the surrounding parenchyma. So at this point, you can say LRTR non-viable. So you can see the temporal evolution of changes. Here we have a patient with an LR5 lesion. 3 months post-TARE. Doesn't look like much change here. In fact, it looks like there may be even more solid arterial enhancement. Remember, this arterial phase enhancement can persist for months after TARE, and it's often impossible to differentiate treatment effect versus viability. So I can't stress the importance of time. It is very important to evaluate post-TARE treatment response. What would be then suggestive of viable disease after treatment in these patients? If you're getting an increase in size after 3 to 6 months. Remember, early increase is okay because of pseudoprogression, so you want to wait some time to see that increase in size. And if you have new areas of enhancement or enhancement in areas of the treated tumor that no longer demonstrated enhancement, suggests viable tumor. So here I'm going to just give you a couple images over time to show you. So we've got our pre-treatment, 1, 3, and 6 months. And you can see the same tumor over time, that evolution of changes you see over time. Early on, you may call this equivocal because we definitely see this peripheral thick nodular enhancement, which over time regresses, and over time the tumor gets smaller. One more time, I'm just going to reiterate that if this had been non-radiation intra-arterial therapy, you would have called this viable. But because it is radiation, we call it equivocal at that early time point. I mentioned pseudoprogression earlier. I'm going to show you a couple examples here now. Here we've got a patient treated with an LR5 treated with TARE. You can see initially there's this transient increase in size, and then it regressed in size. Another patient here, you can see, was a 4.4 centimeter lesion pre-treatment. Post-therapy, it increased to 5.8 centimeters. And this pseudoprogression, like I mentioned earlier, is a result of peritumoral edema, intratumoral necrosis, cystic degeneration, and hemorrhage, to name a few. All right, now let's move on to SBRT, our external beam radiotherapy. Again, just like we mentioned with TARE, the expected post-treatment imaging findings are different than that seen with thermal ablation and non-radiation intra-arterial therapy. So these patients, these tumors that are treated with SBRT can have persistent arterial phase hyperenhancement for up to, but not limited, 1 year post-treatment. They can also demonstrate persistent delayed phase washout. Some of them will immediately non-enhance after treatment, and those ones, of course, are easier to characterize as non-viable. Another confounding issue here is that there's new geographic arterial phase enhancement in the liver parenchyma adjacent to the treatment cavity. So sometimes it's really hard to distinguish what was your treated tumor and what is the surrounding parenchyma, which is enhancing from the SBRT therapy. And then the last thing that's important here is that the tumor itself, again, evolution over time, you want to see stable or decreasing size of the tumor. You don't want to see an increase in size. If you see increasing size, that's suggestive of viable tumor. So here are some examples. Here we have a patient with an LR5 HCC treated with SBRT, and you can see the 3 and 12-month imaging. You can see there's persistent tumoral enhancement. The entire tumor, even at 12 months, is still enhancing. But look at the size. Doesn't really change at 3 months. At 12 months, it's decreased a bit. It hasn't increased. Now, if there was viable tumor at 12 months, you would expect this would have increased in size, and it hasn't. So again, an evolution over time. Early on, you call it equivocal, and I think over time, if it doesn't increase in size, you can be comfortable to switch over to non-viable. How about this one? Here's an LR5 lesion, and you can see at 3 months, there's no enhancement. So this one's pretty easy to call LRTR non-viable. Here's a patient with a 2.9 centimeters LI-RADS 5 HCC, and we'll look at it over time. At 3 months, slightly decreased in size, but it's still enhancing. You can see the surrounding parenchymal changes from the SBRT, and at this point, you call it equivocal because it's still enhancing. Over time, 6 months, and then 2 years, you can see that there's still probably even a little enhancement here, but it's decreased in size. You see the liver itself, that area kind of shrinks down, becomes fibrotic. And so again, just like with TARE, it's evolution of over time. You can comfortably call it non-viable. Here's a patient with an LR5 lesion. At 6 months, you can see the tumor right here, the surrounding parenchymal changes. So you can see sometimes it's very hard to distinguish between the two. There is some residual washout in this patient as well. This was LRTR equivocal because it's smaller than the original tumor. At 15 months, again, the whole thing continues to regress in size. There's a little focus of persistent enhancement. You can see the overlying capsular retraction from fibrosis, and so this was called LRTR viable. But at 18 months, you see new and increasing enhancement, an increase in size, and this was actually biopsy-proven LRTR viable disease. So after SBRT, increasing enhancement, new enhancement, or increase in size are signs suggestive of viable disease. How about this patient? So this patient, this is 7.2 centimeter HCC. This was actually treated with TACE. So after TACE, you see large areas of residual enhancement. So this is viable disease because this was TACE. At 3 months, the patient, 3 months after SBRT, so then the patient was treated with SBRT, you can see there's no real change in size, and this lesion still looks pretty ugly looking. It still looks pretty bad, and there's no change. So at this point, LRTR viable or equivocal, hard to say, because here you can see there's some areas of new nodular enhancement that weren't there before. So this is a hard one. At 6 months, the patient came back, so there was no more treatment, and you can actually see all those areas of enhancement are decreasing, the tumor is starting to regress, that left lobe is starting to shrink down and become fibrotic. So now you can call it LRTR equivocal, and at 15 months, again, same thing, you're continuing to see that regression. And at 15 months, if there was viable tumor, you would definitely expect to see this progress, and there has not been progression. So at this point, you can say LRTR non-viable. So quick review. So what are some of the challenges of treatment response assessment after radiation therapy? As we said, persistent arterial phase enhancement and washout within the treated tumor. If this were other forms of locoregional therapy, that would be compatible with viable disease. So that is why the LI-RADS treatment response algorithm is so unique, because it has that caveat of treatment-specific expected appearance. So if you see that, you can be comfortable over time calling something non-viable. Remember, with radiation-based therapies, there's a relative lack of radiology pathology correlation studies, which limits our interpretation of imaging features as true pathologic viability or non-viability. We can see something's enhancing or not enhancing, but on a microscopic level, is there truly viability or non-viability there? We have those studies after non-radiation intra-arterial therapy and microwave, but not really with the radiation. Early post-treatment arterial phase hyperenhancement demonstrates temporal conversion to non-enhancement with decrease in size without additional therapy, and therefore the LRTR viable classification early post-treatment can be misleading in this cohort of patients and sometimes result in unnecessary retreatment if the referring clinician does not understand the time course for tumoral necrosis resulting from radiation. So that's why it is important for radiologists, for us to understand this, so that when we present these cases at multidisciplinary conference or have a discussion with the clinicians, we can emphasize that point. Alternatively, if we can characterize these as LRTR non-viable right off the bat at that early time period, that may also be inaccurate if you think about it, because if there is ongoing necrosis, but still residual viable tissue on pathology, it's technically not non-viable. So that's why this is a challenging area for treatment response assessment. This is a current gap in knowledge in the application of our LI-RADS treatment response algorithm after radiation therapy because of this relative absence of radiology pathology correlation. It will require many more RAD-path studies and eventually modification of our current treatment response classification systems once we understand it better. And finally, I'm going to end with just a really brief discussion about our systemic and biological therapies. And I wanted to include this because there have been a lot of new approved first and second line systemic and biological therapies for treatment of hepatocellular carcinoma. And so we're going to see more and more studies on patients receiving this therapy. So what do we do with these patients? I'm not going to go too much into this chart, but I'm just showing you this to show you how many trials there are and that have been in the recent, that are going on right now and have recently gone on. The two big ones, the Reflect and Checkmate 459, are the ones that showed were positive studies and what led to the approval of many of these new drugs. Most of these patients who are on systemics or biologics are on clinical trials, and so it becomes very important to use treatment response classification systems in these patients. Remember that the LI-RADS treatment response algorithm is not yet used for evaluation of systemic and biological therapy. So in these cases, we're still using MRESIST and RESIST, which I didn't get into in this talk. Richard did talk about it a little bit a few weeks ago, but I didn't get too much into it. Here's a patient on Nivo, has a large HCC pre-therapy. Post-Nivo, you can see a beautiful response. The tumor is completely necrotic, it's shrunken in size, and so this is an example of a complete responder. Here's another patient with HCC in the right lobe, multifocal HCC in the left lobe, placed on Nivo. You can see that right tumor is decreasing in size or decreasing enhancement, but you can see progression, significant progression in the left lobe. So this is an example of a patient who's progressed or progressive disease. How about this patient on Pembro? So pre-treatment, LI-RADS 5, large lesion in the right lobe of the liver. 3 months after, you can see that there's a significant response. This tumor is smaller, but there are still areas of enhancement, particularly here medial, and so this would be a partial response. At 6 months, most of the tumor has shrunken. Now you just have this residual kind of hypo-enhancing area. This is all the normal parenchyma, so this is a complete responder. And at 9 and 12 months, again, you see that progression of response there, and this patient is a complete responder. So in conclusion, there is an increasing incidence of HCC, an increasing number of local regional therapies that are being utilized, and thus increased complexity in treatment response assessment. Post-treatment imaging is essential for management of these patients and of these tumors at a lesion level as opposed to a systemic level like other cancers. The LI-RADS treatment response algorithm allows evaluation of treatment response for individual lesions. Emerging evidence, a lot of new papers have come out in the past 1 year, is promising for this, the LI-RADS treatment response algorithm for use after thermal ablation and non-radiation arterial-based therapies. LI-RADS treatment response algorithm should be cautiously applied for radiation-based therapies because early post-treatment arterial phase hyperenhancement is common and expected. And what is the future of the LI-RADS treatment response algorithm? We need more validation studies, as I mentioned earlier, for radiation-based therapies, more studies evaluating its use after systemic therapies to see if it's valid, and further evaluation of the LR-TR equivocal category and its utility in these patients. Thank you.
Michelle, thank you very much. That was a great lecture. It was really very informative, and it was really up to my expectation. That's what I did expect.